Good afternoon and welcome everyone. My name is Dr. Eliana Ramirez. I'm the director of the CARE Crisis and Recovery Enhancement Training and Technical Assistance Center. I am here with Mr. Jamie Sellar, and phenomenal mind in the world of mobile crisis teams and crisis now models. Jamie Sellar is part of the partner organization with the CARE TA Center, RI International, and we are so grateful that you are here today. We are in session 1 of Crisis Now, Mobile Crisis Outreach Teams, session 1, SAMHSA Guidelines. So we're going to start off with just a couple of slides introducing ourselves, and then Jamie will take it over. We are funded, the CARE TA Center is funded through the Department of Healthcare Services in the state of California. And I work at CARS, the Center for Applied Research Solutions. While I am most appreciative, of course, for the funding and the institutional support from both of these groups, what we are about to say here does not necessarily represent anyone but ourselves. The Crisis and Recovery Enhancement TA Center is funded to support the MHSA, Mental Health Services Act funded 58 counties and 2 city jurisdictions across the state of California to provide training and technical assistance regarding crisis continuum of care and justice diversion. We are a collaborative based off of multiple agencies, which you can see listed here. As I mentioned, Mr. Sellar is with us from the Recovery International, and many of these additional partner agencies you might be familiar with, such as the National Association of Mental Illness, NAMI, California chapter, C4 Innovations, Research and Action Center at Impact Justice, and Stanford Sierra Youth and Families. Our audiences are universal TTA, like today, where we're doing a training that anyone from the state can come into, from mental health providers across the behavioral health spectrum. We also do this targeted TTA, the county level, and intensive TTA. If you were to go to our website, you would be more than welcome to submit a training and technical assistance request. We provide training and technical assistance at no cost. You might ask us to come in to do a training specifically for your team, or perhaps you have a question about how to access or use data for the purposes of crisis continuum of care, or you're looking for some other key document or piece of information that will help you to build out your team further. Please do go to our website and submit a TA request. On our website, you can also learn about additional services such as webinars like this. We have a virtual conference that's coming up in March. We have a variety of research publications, a newsletter, other resources that are available on our website, including a resource library and an asset map where you can go put in your zip code or click on your county and find out very quickly about all of the MHSA funded crisis continuum of care and justice diversion services in your area. So I talked a little bit about our goal that we are positioned to support the counties and community-based organizations across the state of California in providing crisis continuum of care and justice diversion services. Jamie is going to get in a little bit more around the SAMHSA guidelines and Crisis Now model that are central to the work that we do here. Without further ado, I am going to welcome Mr. Jamie Sellar to introduce himself. I would like just to say one thing. When I talk about Jamie, I talk about him as being one of the most thoughtful and informed people regarding Crisis Now and mobile crisis units. I've worked with this guy for, gosh, I don't know, a year and a half now, I think, Jamie. Every time that I'm in a meeting with him, I learn something from him because he has this unique vantage point as somebody who has worked with mobile crisis teams, who has worked in a variety of settings at a local level in Arizona, but now is working for RI International and helping people not only across the United States, but internationally to really shore up and create crisis continuum of care services that are meeting the needs of the community in today's very tumultuous and high needs times. So without further ado, I would like to introduce you to Mr. Jamie Sellar. Jamie, take it away.
Thanks. I appreciate that. It's always hard to live up to the hype that Dr. Ramirez goes ahead and gives me during these types of presentations, but I'll certainly go ahead and try. I'm going to go ahead and introduce myself a little bit further. So my name is Jamie Sellar. I'm a Chief Strategy Officer at RI International. It's a beautiful title. I love that title. Nobody knows what it means. And really what it is is I have accountability for our agency over consulting, business development, and training. It's easy to go ahead and have a lot of answers and a lot of experience when you've been working in the field for 35 years, which I think I've been doing pretty much at this point in a variety of different settings. But what I really love talking about most is going to be mobile teams. I was fortunate enough to run the mobile teams in Maricopa County for years prior to coming to Teros and being recruited. And really, at that time, Teros and the mobile teams we were running were seen as an exemplar nationally about how teams should be run. We were identified at that point in the Crisis Now paper, which I'll talk about in a minute. And that Crisis Now paper turned into the SAMHSA's national guidelines, which I was fortunate enough to be one of the writers on and heavily influencing how we wrote about mobile crisis outreach teams. So if we take a look at the agenda for today and we advance the slide here, and we take a look at the agenda, really, I'm not going to spend a ton of time because what we're hoping to do is have you talk a little bit. Coaching is a little bit about identifying what situations you're running into, what roadblocks, where your pain points are, where the pressure points are, and seeing if we can start in a quick manner, start to identify potential ways to think about solutions. So today for my presentation, really what I'm going to focus on is SAMHSA's national guidelines, a little bit about the history and the reasoning behind it, why it came about now. Learn what the minimum and best practice expectations for mobile crisis outreach teams are based on those SAMHSA guidelines. Learn really what the best practices or what they would say would be essential functions of mobile crisis outreach teams, so kind of a level 1, level 2, and then really kind of understand what the goals and purposes of mobile crisis outreach teams are. Because what I do know is if we look across the country, every community has some form of mobile crisis care. The reality is that it's dramatically different, and it's not always focused on what community needs going to go ahead and be. So let's go ahead and move on to the next, and I'll talk a little bit about the history of things that were going on. So I got 3 white papers that are up right now. I'm not going to assume anybody's read any of them. They're not tough to read, but they are. You've got to really have an interest in the top to be able to get through it. I think you can get through Crisis Now is about 64 pages with bibliography. SAMHSA's national guidelines about 84 with bibliography at the end. Pretty easy reading, but there's not anything new in there that you probably don't already know. But Crisis Now, the white paper, was basically commissioned by the National Action Alliance for Suicide Prevention. And it was actually in direct response to the Surgeon General's report for the National Plan for Suicide Prevention. And really that came out in 2014. And really what the focus of that was we'd seen a 25% increase in people dying by suicide in the previous 16 years. And about 25% of the Surgeon General's report was, why is that? Why are we starting to see this? And the usual suspects start to creep in. Resiliency, the opiate epidemic, but fully about 25% of that paper was focused on lack of access to care. When people are in crisis, they don't have a crisis-specific course of treatment available to them. Too often, if they're in a crisis in their homes, help is coming in the form of a police car. It's coming from a law enforcement officer who, if we're lucky, has had a couple of weeks training in how to support people in a behavioral health crisis. If they need facility-based services beyond what that officer can provide, generally they're going to get that care in jail or they're going to get that care in an emergency department. While both are very good at suited at their stated purpose of either criminal justice or maintaining physical health, they're not really built for emergency departments, or they're not really built for behavioral health crisis services. So Crisis Now came as a response out of that, and it really came out in 2016 after about a year and a half. And how it came about was bringing together 35 to 40 of the consensus best practice experts in the country, from academics, from hospital systems, from the government, from academia, from provider networks, from law enforcement, from peer-run organizations, to really talk about if we were going to develop from the ground up, what would our crisis system look like? And in order to do that, they started to actually look at parts of the country that were doing very well, that seemed to be doing better. And while nobody was perfect, they focused on the systems that were in Arizona, and they focused heavily on the systems that were in Georgia. And while neither one's perfect, they kind of identified, if you take elements from Arizona, elements from Georgia, sprinkle in some oversight like they're doing in California or Colorado, and sprinkle in a little bit of the ideas that are coming out of New York, really around crisis call centers, you might actually have something. So they took those ideas and put them together, and they became Crisis Now. At that time, when that paper came out, one of the identified exemplars for mobile crisis teams was the agency that I was running here in Maricopa County, running mobile teams 24/7, two-person. So we'll talk a lot about that. So when we talk about fidelity to the model, understand the crisis now came out in 2016. And really what it talked about is inpatient psychiatric beds, not the answer. Talked about emergency departments, jails, and law enforcement, not the answer. Really what it talked about was creating a system that was going to be on par for either criminal justice or physical health. If you've got a heart attack, you're calling a 911, they're sending a medical team to you. If they can't support you, they're taking you to a medical hospital. If that ED can't support you, they're putting you on a medical floor, something that's analogous for that, but for behavioral health. Now, eventually, these two papers, Beyond Beds and Crisis Now, morphed into SAMHSA's national guidelines. Fortunately, I get to work for RI International. We were the lead agency in writing that. We were asked by SAMHSA to go ahead and put our thoughts down. Took us probably about 8 months of almost full-time work putting that down. And 7 of the 14 writers for that program do come from RI. And like I said, I'm fortunate enough to be one of them. But really where my expertise was that was in mobile crisis outreach teams. So we're going to talk a little bit about that. So that's kind of the history of the white papers. SAMHSA right now, that national guidelines is being adopted pretty much in every state. As I mentioned a little bit earlier, I do get to do a lot of consulting. I do consulting at the national level. Currently, we are in process of working crisis system reorganization in LA County. And I think we're just starting to support Tulare, I can never get the name right, county in California to go ahead and support how they're looking at their system and really try to provide a little bit more in-depth consulting to help them move through. If we can move to the next slide. I want to go ahead and start because I want to make sure that we do a little bit of level setting here. So as I mentioned earlier, every community I go into, and I've been in, probably 24 in the last 2 years, everybody has some form of mobile crisis outreach. They've got some kind of mobile teams. And really, if we take a look at what is MCOT, it's mobile, which means it's not facility-based. It's crisis, means it's unplanned. Outreach means it's done in community. And it's a team, means it's a two-person team, or it's a couple of folks that are going out there to see how they can ease the burden of behavioral health crisis in community. And if we take a look, it's great terminology, but it gets morphed into a lot of different things. So when we're talking about mobile crisis outreach teams, we're talking about street level work. So while a team may be mobile, if they're doing 90% of their work in an emergency department, it's not truly mobile. They may drive to get there, but they might as well be stationed there. They might be embedded or housed there. It's not truly mobile. It should be street level work. When we talk about crisis, for us, crisis, the concept for crisis is it's got to be unplanned. And we're also going to talk frequently about if I'm going to say that I'm in crisis or that I'm a crisis care provider, I've got to be willing to work with anybody, anytime, anywhere, which means I have to have very low barriers to access, which means I can't have exclusionary criteria. We'll talk about that in a second. Outreach means I'm going into community again, really that street level work. And we do believe in the Crisis Now model in the SAMHSA national guidelines that this should be done by a team approach with 2 people. We believe it increases safety, and we believe that it increases the opportunity for engagement, which in crisis work, for those of you who are working crisis, you understand engagement is the primary intervention. We can talk about medication, we can talk about diagnosis. Those things are all absolutely important. But in the here and now, if I'm going to help somebody through their crisis and their precipitating event, I have to be able to engage them. I have to be able to connect and establish that therapeutic alliance. So as you're thinking about your communities, I guarantee that 90% of you are going to have some form of mobile crisis teams in your community. But are they street level? Are they going to 1 or 2 places? I'm only going to the jails, the ED. Are they working with anybody, anytime, anywhere? Or are they a little bit more focused on working with only those folks that ask for a team to come out, that are completely sober, that don't have a history of aggression, that are not familiar faces or high utilizers, that are not currently intoxicated, all of those things that tend to go into it. As I start to look at a lot of communities with mobile crisis, they have a list of exclusionary criteria that's a mile long, and then they boast that they have very successful outcomes. 90%, 95% of the people we see, we're able to stay in community. Absolutely. Because the folks that don't want you to come out, that are currently drunk, that are angry, that are acute, you're not bringing into your system to begin with. And like I said, a lot of programs out there are running one-person teams. Certainly understand the need for that financially, but once again, you are impacting the whole system. So as we're talking about mobile teams, understand I'm talking about a street-level response with two folks, and we'll talk a little bit about the staffing model that's really designed to see anybody, anytime, anywhere. So if we move forward a little bit, I can talk a little bit about the national guidelines if we advance the slide one. So I'm going to go ahead and start pulling a lot of things right out of SAMHSA's guidelines, because once again, I don't anticipate anybody's read it. It's I'm sure somebody has, because people talk to me frequently about it, but I never come at it believing that people have read it. So really, national guidelines are mobile crisis team services offering community-based intervention. Once again, street level work to individuals in need wherever they are, including at home, work, or anywhere else in the community that somebody's experiencing a crisis. What I frequently will talk about is you got to go where people live, work, and play. That's what mobile teams should be doing. They can't be just going to the emergency departments and acting as physician extenders or social work extenders in the EDs. We can go ahead and move through. So I want to talk about the minimum mandates for what a mobile team is. So for those of you that operate FSP teams or ACT teams or are familiar with that, you understand that there's kind of a Fidelity model that's out there. You know, if you are doing A, B, C, and D exactly like they want you to do, you've got high fidelity. If you don't, you don't. You can't really say you've got an ACT team if you don't have fidelity to the actual model that you're looking at. Should be the same for mobile teams. So as we're looking at mobile teams, we say the minimum expectations to at least call yourself a mobile team, far from being ideal, far from being what you would want to be working toward, is this. At the very least, I've got to have a licensed or credentialed clinician that's capable of assessing the needs of an individual within the region of operation. I've got to at least have a clinician. And the reason that we look for a clinician is there's some assessments that you want a clinician to be able to do. You also want to be able to get reimbursed by Medicaid. Can't do that if I don't have a licensed clinician able to go ahead and do all of the things that entail getting Medicaid reimbursement. I need to respond where the person is. Once again, where they live, work, and play. I can't restrict my services to only a few places. We see this often with a one-person team. If a one-person team in Maricopa County, for example, I've run on hundreds, thousands of mobile teams. There's parts of South Phoenix I wouldn't go by myself, but I will go with a partner. So if I look at most communities across California, most communities across the country, every community has those places that it's safer to go in pairs. If I don't have two staff going, generally I'm going to ask for law enforcement to support me out there. And once again, that's taking them away from their primary role of public safety to go ahead and act as security, which is not only wasteful for the system, it's not a good use of their time, but it also sometimes attaches stigma into the situation. And I need to connect individuals to facility-based care when I can through the concept of warm handoffs. And I've got to coordinate both transportation, I've got to coordinate the next level of care. So I've got to be able to go out as a license, I've got to assess, I've got to be where they are, and I've got to be able to go ahead and make sure that they have a plan in place for when I leave. That's minimum expectations. And once again, we didn't make it high. We didn't want people feeling bad. We want everyone to know that there's a stretch to move toward. We're going to move from a common ground to something that's a little bit more advanced. And that's what we're going to run into next. So let's go ahead and jump into what we would anticipate being full fidelity. So now it's going to get a little bit more. These are the things that tend to be a little bit more challenging in communities. To fully align with the best practices, you've got to meet those minimum expectations. I need a clinician, remember, but I also need to incorporate peers within the mobile crisis outreach team. Now there's a focus that I need to have a two-person team, and maybe it's not a peer, maybe it's behavioral health tech, psychiatric tech, depending on what your state looks at. Maybe it's an EMT, maybe it's a case manager level person, but I'm really looking for two people on that team. And best case is one of them has lived experience. Because coming back to the concept of engagement as being the primary intervention for mobile teams, if I've got two staff, I've got twice the opportunity for engagement. And what we have tended to see nationally, and what we have really seen here in Maricopa County with its 4.4 million people, and it's 25 mobile teams going out there a day, is that our peers are strong engagement specialists able to identify and meet people where they are at. Full fidelity means I need to be able to respond without law enforcement accompaniment unless there's special circumstances. Maricopa County, we see about 3% of the time a mobile team rolls, probably need some kind of law enforcement out there for safety to begin with, which means about 97% of the time I don't need law enforcement. We're going to talk a little bit about co-response in a few minutes, and I'm going to talk a little bit about how that integrates back into the SAMHSA model. Really, best practice is that these teams are able to be dispatched through a regional call center that has them GPS located to improve safety, but also can start to manage the flow so that you can get people where they need to be or get your teams where they need to be in the least amount of time, as well as all the tracking and data collection that tends to go into that. And really what you need for these teams to be able to do is schedule outpatient follow-up appointments in a manner that is synonymous with a warm handoff. Gone are the days that you can give somebody a card and just say, give them a call tomorrow and hope that they make that connection. So from a full fidelity requirement, not that tough. I want to run a 2-person team. I want one of those people to be a peer. If I can't get a peer because I don't have access to peers in my community or enough peers in my community, I could run with a bachelor's level, but I definitely need that second person. I need to be avoiding law enforcement wherever I can. I want to utilize the technology to make me more effective and productive out there in the field, also increase my safety. And I need to be able to make sure that for the folks that I am stabilizing in community, that I'm able to connect them to the next level of care as they need. Those are pretty much it. So let's go ahead and we'll jump in through. I'm going to talk a little bit about the functions of mobile crisis outreach team. And we can add a few into this. I'm not saying this is a complete and this is end all be all. These are going to be minimum requirements. So what should a mobile team be doing? If I think about mobile teams, the first thing I look at as I'm evaluating mobile team is I take a look at what's their time on scene. How long are they staying on scene? And what I will find is that at least half of the mobile teams that I go out and interview, they have an average time on scene of about 45 minutes. My belief is that probably your sweet spot for a mobile team on scene is about 75 to 90 minutes, because there's a lot of things that you should be doing. Those teams that I see that have an average time on scene of 45 minutes, they generally are assessing and assessing only. They're going out, they're doing a quick level of care, determining where somebody needs to go, and either supporting them in getting there or making a recommendation for them to get there. I can do an assessment in 45 minutes, no problem. I can't stabilize anybody. I can't really get strong engagement. I can't try to help them process their current environment in a way that's going to allow them to remain in community. Really what I'm doing out there is determining what they need to do and getting them there and processing people instead of allowing people to start to process. So the goals that I would look at, one is I do need to do that triage and screening. I need to assess for suicidality. I need to make sure that people are going to be safe to remain in community. I need to be able to evaluate their level of threat to themselves or others. I need to be able to do that assessment. But I also need to be able to step in and find crisis resolution and de-escalate what that current situation is. That's what I'm doing in the other 45 minutes from the initial 45-minute assessment. We believe that mobile teams should be doing a lot of peer support. Once again, primary intervention is going to be engagement. Our peers are engagement specialists. Then I need to do coordination with medical and behavioral health services. I've got to do that warm handoff. I've got to connect them to the next level that's going to help them connect with recovery. And I need to do my crisis planning and follow-up as necessary. So these are the essential functions of a mobile team. What I'm saying is good mobile teams can get this done in about 70 to 90 minutes in aggregate. There's going to be times where you're going to have mobile teams that might need to be out for one particular case for 2 hours, an hour and 45 minutes, 2 hours and 15 minutes. If you've been doing this a long time, you start to realize there is a point of diminished return. If I can't stabilize somebody in 2 hours, the chance of me stabilizing them in 3 hours probably isn't that high. I really need to be thinking about alternate levels of care for them. But these are the essential functions of a mobile team. And as you're thinking about your mobile teams, are they doing all of this? Are they doing a part of this? Are they doing something in addition to this? We can go ahead and move to the expected goals. So as we're looking at the expected goals, I went ahead and pulled this out of the SAMHSA national guidelines. And, I always hate when people read out. I'll let you go ahead and take a look at this. But the big thing that I kind of take away from this is that we should be looking for better outcomes than we get when people are in hospitalization or ED utilization. We should be collaborative. And our goal is resolving current mental health crisis and preventing future crisis situations. This is a nice way to go ahead and say there's a lot of things that are going in here. But if I was going to go ahead and write this again today, and I was going to be much more pointed and much more direct and concrete, what I would talk about is that behavioral health response should avoid law enforcement as the primary caregiver of last resort out there in the field for people who are in a behavioral health or substance use disorder crisis. I should be moving things away from criminal justice every opportunity that I get. I should be avoiding jails as my facilities of last resort for folks in a behavioral health crisis. And I don't do that unless I provide a behavioral health or substance use disorder specific intervention designed to do that, which means I can't rely on law enforcement again. I need to avoid the emergency departments. So if I can meet somebody where they are and stabilize them, the majority of times I decrease the need for higher levels of care, or if a higher level of care is needed, I can get them to a focused behavioral health solution as opposed to an emergency department. I need to be able to provide better long-term outcomes for those that I meet, which also includes helping them be more likely to call again if they're in crisis 6 months from now because of the experience that they had with your mobile teams. I need to provide better perception of care. The folks that we're serving have to feel that their needs were met, that it was effective, and that they're encouraged to take the next step. And reality from a community system, I need to decrease my overall behavioral health crisis spend, and mobile teams do that. So I'm going to go into that for just a minute, and then we can move into questions. So when we start looking at mobile teams and we start looking at what the cost of mobile teams are, it is expensive, but it's not the most expensive thing that we tend to see. Inpatient psychiatric hospitalization is very expensive and generally tends to be longer than potentially needed. Emergency departments are incredibly expensive, and for folks with a behavioral health issue, tend not to provide resolution or even appropriate care for behavioral health issues. They provide safety and they provide security. Same thing for jails, which are expensive when somebody gets into the criminal justice system. And if you take a look at what the cost of operating a patrol vehicle for law enforcement versus the cost of providing a two-person Dodge Caravan driving around, providing care to those who need it, it's dramatically less as well. So when you can do all of these things and do it well, you save so much money within your system, even though the initial outlay feels like a little bit more, that you can start to then convert that savings into other areas of your system that need to be improved. Things like housing, things like employment services, things like same-day access and outpatient counseling, trying to decrease the amount of days it takes to get psychiatric evaluation. So when we talk about all of the goals of mobile crisis outreach team, I need to meet with anybody, anytime, anywhere. They can be drunk. They can have a friend call for them. I've got to go ahead and be that first responder that's out there. And if I do my work well, and I assess well, and I engage well, and I stabilize well, I'm going to get people in community, which gives them the best opportunity for recovery. And I'm going to save my system a lot of heartache and trouble, which is going to come back and pay dividends in other areas as well. So when we talk about SAMHSA's goals and the SAMHSA guidelines, not real complex. You know, do your best work, but go see everybody. Do it in a two-person team. Do it street level, and do it with a goal of keeping people out of other areas of the system that may not be what they absolutely need. If you can do that, you're going to meet SAMHSA's guidelines in spades. So that was my presentation. I think we're moving into Q&A.
Oh my gosh, I told you, I told you this guy is a wealth of information. That was phenomenal, Jamie. Thank you so much. The purpose of the cohort coaching series is that we meet for an hour. Each session, Jamie is going to give a brief presentation, and then we're going to leave lots of time for group discussion. So questions that you might have, you're welcome to pose them to Jamie. You're welcome to share them with your colleagues here as well. So I see that there is one question in the chat already, and let's go there. So Carrie asks, how does mobile crisis work when the mental health system is gravely impacted and may not have sufficient care? Yeah,
it's tough. Really what we talk about, when I talk about functioning crisis systems, with the idea that there's none that are perfect, but I do talk about those that maybe you're doing a little bit better. If we had to rate them on a scale, maybe doing a little bit better. I do focus fairly heavily on Maricopa County, just because I think that based on a lawsuit in the 80s, we were actually forced to do work the right way. So our mobile teams do have a plethora of options for folks in community if they need that higher level of care. Your community may not have that. But first and foremost, when we start talking about key performance indicators and what outcomes you can start to expect with a mature mobile crisis outreach team, and we'll talk about key performance indicators actually in one of the next, I think this is the third session potentially, where we talk about how you go ahead and measure success out there at the street level. What we'll see in strong communities that are seeing everybody, whether they're intoxicated or voluntary or so forth, is about 70% of the folks you see. If you give them the right level of service, you're going to be able to remain them in community, which means that they're staying where you met them, whether that's the home, whether that's the homeless shelter, whether that's on a friend's couch, but you are allowing them to remain in community, which does decrease the burden on the other program, the other systems that are already in place. But the reality is I can say wholeheartedly, I've seen systems where mobile team members were burned out because they did not have a disposition that they could go ahead and start to move into. So what I can tell you is that when you start doing this and you do it with good fidelity, the number of people that need to go to a higher level of care does decrease. But you need to then bring along the rest of your system to go ahead and meet that need. So as I do crisis system redesigns, really what I talk about is I generally either want my call center or my facility-based drop-off center to be the first priority. Because if I start with mobile teams and I don't have a place to drop off, well, where you drop off on somebody that you can't. You drop them off at the emergency departments. You drop them off at the psych hospital if they have a bed available, which is probably few and far between. So in reality, you still are doing good work. You're still stabilizing as many people as you can, but you still hate the dispositions that you've got. So I always talk about mobile teams actually coming up last because I want the systems in place to go ahead and do. So I do think also when you don't have those other systems in place, your mobile teams get more heavily relied because people's acuity tends to get a little bit higher because their needs are not getting met. So you're going out more. So while I can't say that there's an easy answer if you don't have the rest of your system in place, what I can tell you is you're still going to be dropping them off at emergency departments. You're still going to go home wishing you could have done something different, but you're starting to collect data that then can push other changes in your system. So once again, how much does an emergency department drop-off cost the ED in the state? Nationally, it's $1,233. Every time you drop somebody off, there's somebody paying $1,233. That's either in lost cost and anticipation for the emergency department, or that's what the insurance companies are tending to pay. But the average ED cost for behavioral health is about $1,233. So if I can start to make a case that, we dropped off 800 people last year, I know exactly what that's going to cost in just straight ED visits. I can then go ahead and start to extrapolate how many folks got put into a long-term inpatient as a result of that if they had another option, I can then start making some decisions from a business viewpoint to help pressure my system in creating some of these other systems. Not going to happen overnight, but at least I now have a treatment plan or a trajectory that I can start to work to start changing what's going on. So I feel for you. If you're running mobile teams and you don't have those resources, you're going to go home stressed a lot. Know that you can bang on the system enough to go ahead and make those changes and understand that in the state of California, change is coming. Funding is coming like no other time. Like I said, LA asked us to come in and redesign their system. We're talking hundreds of millions of dollars to redesign everything they need. And we're starting to find opportunities to go ahead and get that funded, including, adding maybe 20 more facility-based programs within their community. So it's coming. Hang in there, gather your data, talk about what the impact would be if you had a crisis facility to drop people off to, or if I had same-day appointments with an outpatient clinician, how many folks I could keep out, and then start making those business cases up. And as the money starts to roll in, you'll get there. But yeah, it's going to be a gross 5 years for you guys. But after that, you're going to be like, wow, this was, you're going to be telling the new guys what the stories of the old times were like.
I appreciate so much, Jamie, how you talk about the dollars and cents and how to make change in systems by collecting data and making a case about the cost efficacy of using a mobile crisis team within a system that's set up to do what it needs to do across a continuum. I also just want to remind people, if you go to the CARE TA website and you put in a TA request, we could pair you up with Jamie and his colleagues at RA International to get you starting to think about even some of those first data points, perhaps, to make that case, and then to move into a larger kind of consultation. Please use us for that reason. That is exactly why we are here. It looks like you wanted to add something else, Jamie.
Yeah, I was going to say the only two things I've ever seen change systems is lawsuits and money. It's the only thing in the last 35 years I've seen. If there's a lawsuit, things change. Or if you can make the case that I can save money by doing something better, more effective, that makes the change. So I work in Arizona. Like I said, I ran the mobile teams in Arizona. The reason that Arizona is seen as an exemplar is because of both of those reasons. There was a lawsuit in the 80s because we were keeping people in our state hospital for years, absolute years, taking away their constitutional right to freedom, putting them in an inpatient institution for years. And keeping them far beyond the point that they had stabilized. But we didn't have any community-based programs to put people into. And the psychiatrist knew if I discharge somebody to the street, I'm going to see them in 2 weeks. So we're going to go ahead and keep them. We're going to continue to violate their civil rights by doing that. Huge lawsuit, Arnold versus Sarn, look it up, basically made the state of Arizona decrease the amount of psychiatric state beds for civil commitment to 55 for our county of 4.4 million people. So you start doing the math, you start realizing that's nothing. And if that's nothing, then what we need to start doing in order to keep people out of the state hospital, because there's no more room, is start treating people in community. And what services are going to help people remain in community? Good call centers so that they can call when they're starting to feel a little bit flap and twirly. Good mobile teams that can come out there and support you with very low barrier to go ahead and just help you through those rough times, keep you from escalating, or connect you into services, which are always tough to navigate. And you know what? If I do need facility-based services, I shouldn't go to an 11-day inpatient hospital to begin with. I should go to a crisis center that helps me process my situation, hopefully stabilize me quickly and get me back into my outpatient program, who's been seeing me for years, get me back to my natural supports, get me back to my job potentially. And as that started to come through, it was a result of a lawsuit, but Arizona started to realize that in our system, from a Medicaid viewpoint, for every dollar they spent on crisis services, they saved $2 in unnecessary inpatient spend. So Arizona, from a psychiatric inpatient bed perspective, has fewer beds per 100,000 population than any other state in the country. We have really very little psychiatric boarding in our emergency departments. We do not have police complaining about wall time. Our emergency departments are just not stacking up because we're diverting. So Maricopa County, 4.4 million. We run, probably about 18,000 mobile teams a year, maybe 20,000 mobile teams. About 78% get stabilized and remain in community. And the rest are pretty much coming to a facility to start to sort those things out. And all of those folks bypass jail or EDs.
Jamie, thank you so much. This is an incredible amount of information. And I know that people are furiously taking notes and paying attention. And again, this is just the first of 8 sessions in this series. I would like to bring up our polling questions, if we might, to get a little bit of a sense of who's here. We're going to ask you questions to find out how you work with mobile crisis teams. You might or might not. No answer. There's no right or wrong answer. We ask these questions so we can get a sense of who's here, and as we plan out the subsequent 7 sessions. So this first question is, does your county have a mobile crisis team? If so, which type do you have? Do you have a co-response model? This is a clinician who's paired with a law enforcement. Do you have a civilian mobile team? It could be one civilian clinician, or it could be a pair, a clinician and a peer, or a clinician and other professional. Or do you perhaps luckily have both kinds? You might be one of these counties that has both a co-response model and a civilian model. And if you don't know, that's okay too. You can put that into the chat. I want to thank, while people are continuing to answer, I see here that we've got just about 51%. Oh, it's going up still. People who are responding. I want to thank Andy Pena, my colleague, who has put the Care TA Center TA request form in the chat. So if you'd like more time with Jamie and his colleagues at RI, please do place a TA request with us. We would love to connect you. Okay, and now we are up to, let's see, 67%. Interesting, Jamie, that of the people who responded, 57% that they said they have both a co-response and civilian model. Interesting.
It is, and I think it actually delineates a little bit of a difference and some things to think about when we look at SAMHSA's model. So overall, once again, the goal of mobile crisis should be to divert away from, law enforcement. But the reality is that there is an intersection between behavioral health and law enforcement that will continue long after we're gone to be important. And it really revolves around those folks that are incapable or unwilling to make a decision in their own care and have some danger to self or other behavior. So if we take a look at a county, just a random county, I can have a civilian mobile team that goes out. If that person assesses as high suicidality, you go through your entire assessment, you say, I think that there's at least enough risk here to go ahead and place this person on a 5150 through all state regulations and mandates. How am I going to go ahead and get him to the hospital? I can call an ambulance, but if he's not going with me, as evidenced by I'm doing a 5150 as opposed to voluntarily taking him somewhere, how am I getting him in the back of an ambulance? Those EMTs aren't better at talking to folks than I am. I'm going to need law enforcement. So really what we tend to see in crisis work at the mobile team is that there are needs for both. How it would look in Maricopa County is all teams are civilian. And if they get into one of those situations, they request police to come out and support. But they're kind of leading that drive. It's just the police are there because there's a public safety issue. There's a potential for a hands-on intervention out in the street to go ahead and enforce that 5150. If I take a look at other communities, they run with embedded law enforcement and clinicians, and they might do that 100% of the time. I think that there's room for both. While the guidelines in SAMHSA would say run civilian mobile teams and bring in patrol when you need to, I think there's opportunity for both. But what I want to be able to do is make sure that each type of team is working with the right type of people. Too often I see folks that really would benefit from a civilian only mobile team having law enforcement out there in a co-response. Co-response is expensive. Officers take a lot to be trained. Their retirement, pension, the unmarked cars, their training. You take a look at what it costs to run a civilian mobile team of a clinician and a peer, and what it costs to run a police and a clinician, usually about twice as much. So I get more bang for my buck with the civilian teams. So if I can go ahead and increase my civilian teams and work with the folks that are appropriate for a civilian team and only bring in either a co-response or law enforcement as patrol when needed, generally I'm getting more bang for the buck, but I'm still meeting what that community need is. And I'm not introducing somebody with a gun and police academy training about command and control into an environment that's unnecessary for that level of safety and security to be into it. So I'm not going to say don't have co-response, even though it's not really mentioned a ton in SAMHSA's guidelines. What I'm saying is try to match up what the person in the community is going to need with what you're providing in real time.
Excellent. Thank you, Jamie. We're getting some comments and questions in the chat, and I am aware of our time here. It's 3:52. So I just want to elevate that one person is asking, where do we find the charts that are showing the cost? And if you might, if it's okay, I'm just going to read through a couple of these comments here because I think some of them might be quick responses. The second part of that question is, do the charts include who is responsible for payment, county mental health plan, managed healthcare, Medi-Cal, or commercial? Steve, who has posted in this chat, says, we all seem to know the problem, yet it is hard to determine who to address to fix which blocking point. Mobile is now funded by county, DHCS grant, and city using CARES Act. Lots of money. Where is the California needs gap analysis?
Yeah, so really what they're doing at this point is I've seen more counties actually starting to see. So if you think about a couple things from a funding viewpoint, what the federal government has said through CMS is that if you're running a two-person team and you've got 24/7 coverage, and whatever variable that means, it means that you don't shut down at 10 o'clock at night. You still see somebody at 2 o'clock in the morning. Then really what they will do is the federal government pay 85% of what Medicaid or Medi-Cal is paying for that particular person. So what we see in California, just like most expansion states, is about 70% of the folks that do get mobile services are probably Medi-Cal eligible. So if you think about 85% of the funding for that coming from the federal government, if you're running with Fidelity to this particular model, the federal government is paying for the overwhelming majority of your mobile teams that are out there and running. The challenge starts in parity. So if I've got a Blue Cross Blue Shield commercial plan, they're not going to pay for mobile teams. And the reason they don't pay for mobile teams is because Medicare doesn't pay for mobile teams. If I'm working with somebody who's uninsured, there's nobody to fund that. So what the state's starting to look through, and you guys may know the CCMU grants, there's funding that's starting to come through to go ahead and support, at least for the next 3 years, the creation of the infrastructure to get your mobile teams up, the operations, with the idea that in the next 3 years, parity laws are going to start to force all insurance companies to pay for this level of care. And you've got 3 years, basically, the federal government paying 85% of the Medi-Cal bill, which is going to be phenomenal. So each county has to come up with its own plan on how to access those funds, whether or not it makes sense for them to have Fidelity to get that, and who's going to go ahead and be those ultimate funders. But if there is a gap, once again, if there's a gap, if it said, well, we can't run it because we don't have enough money, at some point, somebody is paying for it, because if you're not slowing them down in the field, if you're not helping them stabilize in the field, they're going to the emergency department. Somebody's paying for that. They're going to jail for 21 days on a misdemeanor charge for criminal nuisance or trespassing or drunken disorderly. Somebody's paying for that, and the court costs and the public defender on top of that. So people are already paying for that. You've just got to really talk them into diverting it back into more preventive and the right level of care at the right time. So funding's coming. There's more money coming in. It's like, a grizzly bear grabbing salmon, swimming up. You just got to figure out how to grab and what you want to go ahead and grab coming in. We can help with some TA and have some of those discussions. But those of you who are working as a pass-through for Medi-Cal in your communities, you already know what the federal government's going to pay. As far as how much a mobile team costs, two-person mobile team in Maricopa County, $270,000 a year, 40 hours a week. That's all in. That's a van, that's 15% indirect allocation, 10% direct, that's supervision, that's insurance. That's the washer and dryer at my office, because people might be coming back with bed bugs. In LA County, I just had this conversation with their Department of Mental Health and their office of the CEO. They're estimating it at $350,000. So chances are you guys are probably somewhere between 270 and 350, probably more between 310 and 350, depending on what you're looking for, all in to provide 40 hours of coverage. Now, the reality is if I need 24/7 coverage, I need 4.2 teams. So if it's 350, I need to multiply that by 4.2 to say if I've got one team 24/7, that's how much money I need for a dedicated team to run these mobile teams. But for you that are in rural and frontier areas, you may not have 24/7 dedicated teams. You can still meet Fidelity. If I'm an old clinician. I used to carry the pager. That pager would go beep, 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 and I'd have to leave the movie, find a payphone and call in and say, what's the crisis and where am I going? But if you've got staff that, maybe carry a pager and at 2 o'clock in the morning, appear in a clinician, get that call, and they wake up and they drive to scene, that's still meeting the standards of CMS because I'm still not closing the doors. So it's how you integrate all of that to get that federal match and take advantage of the other opportunities that are coming in. The other thing that I'm going to tell you as you're thinking about it, every 100,000 people you've got in your community, anticipate seeing 768 per year with your mobile team. So if you've got 200,000, I'm going to see 1,500 people, which is 4 or 5 a day. LA County's got 10.6. We anticipate 70,000, I think, people being seen a year. Yeah, it's easy to staff that. I mean, constantly in motion. It's tough if you're rural and frontier and you're going to see a person a day, but you want 24/7 coverage. I understand that.
So without further ado, please join me in thanking Jamie Sellar for this phenomenal presentation. And thank you to all of you for the work that you're doing. It's hard to do your work any day of the week, but especially in 2021, 2022, when everything is just harder for kind of everyone. So thank you so much, Jamie, for being here.